So are you going to hire your own medical oncologist? Are you going to partner with somebody in the community? Have you guys thought that far down?
We keep thinking about that, haven't made any decisions yet.
Ken?
You know, that's a, you know, I know Brian and I think similarly about this. I think one of the things he said though is, yes, it's a landmark trial. I think it is a game changer, but like Brian said, it's a very small select group of our patients. So now with maybe the way screening goes, maybe we'll start to see an increase of these patients, unfortunately. That's obviously a risk. But for us, we haven't really looked at hiring a medical oncologist. I think for this small subset of patients, we have a good relationship with our medical oncology colleagues in the neighborhood, so we refer to those patients. Obviously, we try to treat everybody ourselves with all the other advanced therapeutics, but again, it's a small subset of patients, so we refer those.
Can I make one comment about it? You know, everybody's right. It's about, you know, at least in the United States, people say it's about 5%. Other parts of the world, it could be much, much higher. But keeping it to the United States, but it's interesting to note, of the 5% of our patients who present with, you know, advanced metastatic disease, and presumably of that group, most are the high volume, more than 4 lesions and or visceral metastases. Their performance status is actually very, very good at that time. It's only 6 cycles as opposed to the 10 cycles of the TAX-327 and the 9916. So it's a shorter duration of chemotherapy. Their performance status is better. They're younger. Their adverse event profile in that study was actually much better tolerated. But here's a more important point. Of the roughly 30,000 men who die annually, about 20 to 40% are coming out of that 5% group. And it's about 60 to 70% that are coming out of the PSA relapse going on later on to CRPC. So even though it's a small percentage, there's a very high mortality rate in that group. And so the data is the data, and a 17-month OS at the median for those with true high volume disease is pretty darn impressive, and was for the most part very well tolerated.
Yeah, and again, I think obviously there's lots of questions. You know, we were talking to David Quinn from USC, who's very active in this, because I think 75% of these patients on CHAARTED had never received any treatment. Now, there was a subgroup of 25% that actually had treatment, so they're going to be looking at that and see what that time is to relapse. So again, I think there's going to be more and more looking at this. There's going to be lots of analysis of this data. So, Chris, you know, again, we talk about this progression of disease, and we all know that, again, if we move away from this patient that presents with metastatic disease, our typical patients, as we've talked about, they do well with definitive therapy, but we all know there's going to be a subsegment, higher Gleason's, T3 disease or greater, who will start to have biochemical recurrence. We start them on ADT, and again, a fair number of those people will do well. But then we get into the castration-resistant prostate cancer patients, which, again, I think we all understand the importance of the androgen receptor. We're recognizing the fact that these patients, to me, once you put them on hormonal therapy, this becomes a whole different ballgame. PSA becomes less sensitive. So have you guys at AMP adopted or adapted any type of protocol in terms of monitoring these patients once they start to progress, PSA progression on hormonal therapy?
I think the answer is yes. You know, if you're not looking for disease with radiographic imaging, you're going to miss it. And I think that the trouble that I have in our practice is to try and convince my partners that these are different diseases. Clinically localized disease, when the NCCN guidelines say get a CAT scan only if the PSA is above 20, is very different than the patient who has some sort of BCR. So the simple answer to your question is yes. One of the things that we've looked at is the RADAR study, which is sort of an imaging study that was recently published that tries to give some guidelines on this, and it really has a broad sort of broad-based appeal of a variety of different people involved in the specialty treatment of prostate cancer, both urologists, medical oncologists, and really, I think in this particular disease space, if you have a patient with a PSA above 2 on hormones, you've got to start looking for doing some imaging on them. Now what you do, bone scans or CAT scans, maybe sodium fluoride scan, is maybe a different discussion, but you've got to do some imaging. And I think that depending on what the PSA dynamics are, you must re-image again. You know, if the PSA is going up, re-image, do it often and do it frequently. You know, one of the things that is out there is that Dendreon has unpublished data that looked at a bunch of patients, and 55% of them had metastatic disease with a PSA less than 11. And a lot of my partners, they wouldn't even think to do imaging until their PSA is 20. So somewhere, you know, is the disconnect between imaging early, because the thing is that we have now, with all these other things that are available, a variety of clinical studies and moving the treatment to earlier in the disease space, not when a patient has floridly metastatic disease and they're got one foot in the grave, when they have good performance status, when their PSA is lower. And one would think that by treating them earlier that there might be benefit.
So